Okay. So, Bang.
Yes. Okay.
Oh, okay.
Good morning and good evening for all our friends in the ICC webinar. Today is our 10th webinar online. We are so happy and so honored to invite Professor Zung-Chung Chen to give us a very special topic. As we know, Dr. Chen is a very worldwide well-known expert field of the treating the patient with microtia. So today the topic will be shared is the differences microtia reconstruction using the rib cartilage and the medpor. So today our another co-moderator is the Dr. Junior too. So he now currently the student of the Professor Ren Chen as well. So I think we can start the topic. Please, Dr. Chen.
Hello, everyone. Thank you for joining the web. Actually, I saw the list of the audience. We have several experts, including Dr. Yamada, Peter. So, Bang asked me to give a talk about the difference between autologous tissue and medpor surgery, microtia surgery. Actually, nowadays, because we have several different kind of commercial product available, so medpor we should change into a term high density porous polyethylene. And between these two fields, some part we knew very well already. For example, if we do the cartilage surgery, the doctor prefer the PE surgery may criticize about the donor site. But actually, if you treat the donor site well, I mean, if you preserve the precondition and put the leftover cartilage back to the donor site, and the donor site, the fallen could be quite minimal. I mean, the donor site won't be not so scared. You can see this special patient, bilateral case, after about 15 years follow-up. You can see the donor site looks quite well. Even the skies, I think, could be beautiful. But anyway, in most of the patients, you may observe a little bit loss of the chest contour. And but in some adult patients, it could be very good. You can say in pediatric patient, maybe the donor site will be more contour change than the adult patient. So, but for me, the donor site mobility is not that kind of a problem. The difficult part for me when you do cartilage surgery is how you create the beautiful framework in every different patient, because in every patient, the quality, the amount of the cartilage could be different. During the fabrication process, you may not be able to control everything. Also, for the medpor surgery, I mean, for the polyethylene surgery, the exposure is the issue we most often criticize. I think it's true. You may see many exposed cases, but one thing about the exposure you may not know, even after long-term exposure, for example, in this case, after 8 months exposure, you can still rescue your imprint by covering the enough soft tissue with adequate coverage, and the contour still could be remained. So this is one thing very special about, could be unique about the PE surgery, because in cartilage, of course, exposure is quite rare, but in cartilage, if you have any wound, without coverage for 1 week, and later in long-term follow-up, you may observe some resorption. Definitely will happen. So for me, the medpor surgery or the PE surgery, the difficult part is because usually the coverage in PE case is more difficult, more complicated than the cartilage patient. So not rare if from time to time, you may observe your patient with partial loss of the skin flap or skin graft. So, but because you know that once you lose some flap or coverage, the color, the texture will be not so good as because compared to a case with a beautiful recovery. So it's a difficult part for me in PE case. Nowadays, most of my patients are still microtia patient, and I did few cases about, for example, a trauma case or after invasion case. In this case, we still use very often the cartilage. You can see in this case, I think I did a quite beautiful fabrication, and the coverage is okay. We use the TPF and the skin graft for coverage. And later you can see the recovery for me is quite good. The contour, although still some skin color redness, but as the time passes by, it will be better and better. And another case, so the courage, if the case they don't, I mean that if they can accept the courage, the condition is good, it seems no reason. There's no reason we don't use courage. But you know, for a cartilage surgery, as in this microtia patient, you know, before the surgery, you need to know the quality of your coastal cartilage and the fabrication course, the process. You may not say it's very difficult, but it's a time-consuming process, especially if you want to make a very good fabrication. You need to assemble a cartilage piece by piece with wire fixation and do the carving. So usually it takes maybe 1 or even 2 hours to complete all your fabrication. You need to assemble the cartilage piece by piece. Of course, in this case, every doctor, they have a different approach for fabrication. And you may notice, for example, Dr. Furman, Dr. Nagata, their fabrication method is a little bit different. So, and also you may not always need to do the very complicated fabrication. But if you want to have a very good profile, usually it takes time to complete this procedure. Okay, it's probably you can say it's kind of artistic work, but what you need is you need to have some practice and you need to obey all the discipline so you can get a good outcome. But if you want to do a relatively simple fabrication, not so complicated, not so many layers, at least you should remain the strength of your framework. I mean, at least you should maintain your width and your length. The framework should be strong enough to tolerate the tension of the skin envelope, so you can maintain your framework in kind of the tense skin, under a little bit tense skin, so you can get a long-term good outcome. Otherwise, after elevation surgery, you may observe the collapse of your framework. Okay, I just speed. Okay, this after almost after the fabrication complete. Okay, and then we will put the framework under the skin envelope. I mean, in the ordinary case, just put directly under the skin. This is good part about a coastal cartilage surgery. Usually after 2 stages operation, you can make your auricle projected in a good position. And because we put the cartilage directly under the skin envelope, so usually the healing will be primarily, that means the scar could be good. the color could be good. The texture will be very, very close to the normal skin and to the face. Okay. And you can see in this short video, even the microtia side, the skin is not so, a little bit tense, but once you make everything well, after you apply suction, you can take out the suction immediately after the surgery, and the skin envelope will remain attached to the framework. You don't need any drain. I mean, you don't need put any suction. Or nowadays, in most of my practice, I don't use the bolster suture. I mean, the suture bolster. I just cover the wound with tegaderm. Then use the negative pressure to suck out all the air. And the tegaderm can remain in this condition for about 10 days. And you took out the tegaderm, remove the suture. So recovery course could be quite easy for the patient and also for doctors. Okay, so you can see the skin color is good, the texture is good, although a little bit tense, but you can say it's good. It's quite, I cannot say it's easy, but it's not so difficult actually in most of the case. But why, but you know, because of courage, you cannot always guarantee the good result. I think part of the reason is we cannot control the fabrication. You cannot put your skin envelope in very good condition, so you can. In this is my own case. After elevation surgery, you observe some shrinkage of the framework, so the contour won't be good. This is done by another doctor. You can see although the skin seems thin, but the position and the contour not good. In this case, I think this probably initially is a low hairline case, and the patient remained discharged for from the wound for more than 10 years after the surgery. And so, I mean, for cartilage surgery, if we are not able to do a good fabric, do a very good fabrication and do a very good skin coverage, even we think the cartilage is a gold standard for surgery, it won't guarantee anything. And another thing I observed in my patient, for example, in this case, is initially it looks very good. I even published this paper in PRS talking about a kind of a new skin design for this surgery. But you know, after 8 years follow-up, I saw some irregularity on the face of the auricle. Although it seems did not progress towards very severe condition, but you can see very clear irregularity, and even some area you can see a little bit show of the wire we put in. Yes, in some cases we can observe even after 10 years, the patient remains stable, or even the contour, the cartilage looks even stronger than before. But I also observe in not many, but you can see certain amount of my patient after 10 years, 8 years follow-up, you can see some very severe resorption, especially along the helical ring. So I think all these issues, actually we cannot control very well. I think about a blood supply is something we don't know very well, actually. In some of the case, of course, if this is a secondary case, you can see all the effort done by the previous surgeon. And he raised the TPF, he put a skin graft, he put some block for elevation, but you cannot just see a very clear contour. I did this case maybe 10 years ago. At that time, I thought I was good, so I can do a very, very good fabrication. Yes, I do a relative good fabrication. And we took out when you took out the previous implanted framework, you know, this is kind of technical barrier because the surgeon, he may not be able to create a very beautiful framework, but probably the age when he did a surgery, the kid is too small, so he cannot get enough amount cartilage for fabrication probably. In this case, in the second stage operation, we use the deep layer fascia for fabrication. This is a technique I learned from Dr. Nagata. I saw many of his cases in his clinic, like this kind of procedure. Okay, and several years later, still remain good. But the difficult part about cartilage is that you cannot always get very good quality of cartilage for fabrication. Like this case, the synchondrosis is all cartilaginous part and attached very well. It's very rare. Of course, in this kind of case, you can get a very stable base framework, so you don't worry too much about collapse your framework. Another case, the synchondrosis, all cartilage portion, and the cartilage is very thin. So in this case, you can say you are lucky, okay, but you cannot get this kind of good cartilage in every case. Even in adult patient, still sometimes you have some condition about cartilage. And the other thing, initially we did a projections elevation surgery in the second stage, again with the cartilage. At that time, usually I use another donor site because I want a fresh cartilage for elevation. I want to get a stable elevation, but for me, it's not a really pleasing appearance because there's a second donor site. So gradually, I changed my practice in the elevation surgery into porous polyethylene. Nowadays, we are still using porous polyethylene for the elevation surgery. I think this kind of approach could be quite reasonable because for elevation surgery, we need to put a fascia over a supporting part, and we'll put a skin graft. So I think porous polyethylene in this condition works very well, even better than cartilage, because in nowadays we can by compare a digital image of both auricle, we can customize this projection block for the second stage operation. So for me, one good part about cartilage surgery is we use the porous polyethylene for elevation. That means we may be able to control projection better, and probably we may be able to create better profile. This is my experience at least. So porous polyethylene for me is not bad for a surgery. Depends how you use it. This is a case. The patient, she came to my clinic, asked for help. I saw her wound. Oh, it's a kind of secondary case. The patient, she went to another institute and receiving the medpor surgery. But anyway, the result, they cannot complete operation, just end up with a lot of scar. And I also noticed the TPS has already been used. But when I check out data profile, I was very surprised to find her picture on our data profile, data bank. That means the patient initially is our patient, but why she came to another hospital? Because we did not offer what they want. They don't want cost cartilage surgery. They just want kind of artificial material for maybe they think it's easier, it's less painful for the patient. So I start to think about this issue. So I think we should give the parents more options. We should do the surgery depends on what they want. Although it's probably not the main trend, or even not what we prefer very much, but we should listen to the patient. So I start to use, in some cases, I start to use the porous polyethylene, but initially I don't want to use this kind of 2-piece porous polyethylene. Nowadays, this kind of product is still available, but some companies, they start to offer some custom-made implants, but from the first beginning, I tried to make the framework by myself by carving the block. I think I presented this several years ago in Wyoming, in USA, when we joined the meeting. So at that time, I carved the framework by myself from block into the framework. This is the final result. Of course, when I saw this picture again, I realized nowadays I won't carve the medpor into this kind of thing because fracture could happen easily. Anyway, nowadays in every patient of my patient, no matter what they want, if they want the cartilage surgery, either polyethylene surgery, we'll take the photo first, and we'll also do a 3D image, and we'll do some simulation based on your 3D image. I think the simulation is kind of tricky, since simulation, from my point of view, won't make your surgery better, but it's a kind of good reference anyway. And in some patients, if the position of the Raymond is in a very dystopic position, you have the better chance to discuss with the parents to give them some hint. The operation could be difficult, and probably we need another routine approach. So I think it's good for communication. And after a 3D image, we'll again take the image from the contralateral auricle, and our specialists will analyze and do the image work on computer. And this is the normal side auricle, and we'll take all the noises and get what the shape we want for the contralateral auricle. And then we'll take all the skin part. This is theoretically, for example, 1 or 2 millimeters. The thickness of the skin envelope will take out from the auricle, and then to get the shape for the ideal imprint we want. I think for this kind of imprint, the shape, I think it's good for both cartilage and artificial material group patient. So after this, you can see, and we'll mirror image to the lesion side. And then based on the data here, all the imprint, if you use the porous instance for surgery, we'll do the imprint based on the data we get from the mirror image of the normal auricle. And we also preserve this many data image for the bilateral case, so they can choose, or they can the parents can decide what kind of the template they want. So we'll use the template for both side surgery. So okay, and about the medpor surgery, I think I learned all the procedure from Dr. Ranish, and but now for the medpor, for the porous polyethylene surgery, I think the concept you can say is similar to the cartilage surgery, but it's a little bit different because usually what we need is a very big amount of tissue. For example, for the TPF, usually we take a lot of TPF. Usually it's more than 11 centimeters in width and more than 11 centimeters in length. And this because it's a single stage operation, so we need a lot of skin graft from the contralateral auricle, from the scalp, or from the medial arm. This is usually donor side we take the skin. So you can observe in the medpor case, usually the patient the surgical age could be very young, maybe 5, or some doctor even do the surgery at age 4. But usually we do the case after 5 years old. You can see because we break all the limitation of the skin envelope, so you can create a very deep very deep concavity, and you can create a very deep resource triggers area. And if you put enough skin over the framework after TPF coverage, you can get very good contour in a single stage operation. So you can see after the operation, usually the patient, they are happy and they don't experience too much pain actually. So the course could be also not so difficult for the parents and also for doctors. But for the medpor surgery, as I show in this case, usually in some case, usually we took a long time for recovery. I think it depends on the surgeon's coverage. In this case, my coverage is just so-so, just not so perfect. So you can see after almost 1 year to get a very good out contour. But you can observe the color and the texture of the framework not as natural as what we did. What we get in the cartilage group. So you can see in the medpor case, the contour could be good, but the color and the texture may be a little bit inferior to the cartilage group. You can see this case, a very good outcome. I mean the contour, but the color and texture not good. And probably the scalp will be more prominent than the cartilage group. But how about in the perfect recovery case? I think in the perfect recovery case, in porous polyethylene case, the result is better than cartilage because the contour could be very good. It could be very thin. The posterior sulcus could be very deep and kind of natural looking. And if the recovery is very good, the color of the skin grade could be as natural as the normal auricle, so it could be very good. Nowadays, I did this case about 10 years ago. At that time, you can see the patient is 16 years old, 16, but you can see the cartilage is so calcified. By that time, I still use the calcified cartilage for publication. But nowadays, if the condition happen again, I won't do the cartilage surgery in her condition because I feel regret. It seems for me, I cannot make the framework in a very good condition, and even some part a little bit break. So I did this case 1 year ago. Again, I saw a condition like this about severe calcified cartilage. So at this time, I just used the medpor for porous polyethylene for surgery. You can see the mirror image imprint. It looks quite pleasing for the surgeon actually, and the cartilage is a little bit complicated, but because the recovery the healing is quite good, so you can see after 3-4 months the contour become very good, and gradually the skin color just very close to the normal auricle. You can say that the kind of result is better than the cartilage. But of course, you may criticize the cartilage envelope probably won't be as stable as the cartilage group. I agree with this kind of criticism, but you can still get a very good outcome at least at this moment. This case almost at the same age as the previous case, but because the cartilage quality is good, so I don't hesitate to use the cartilage for surgery. Even in the second stage operation, because her leftover cartilage is so big, I took the cartilage again and do the verification. You can see the projection is still quite nice, and the skin color and texture. 1 year follow-up is more natural than the porous polyethylene group. But how about another 10 years later? I don't know. Probably you can see some resorption in this case. In another case, of course, it can remain very well, but maybe see some resorption. But in the medpor case group, it can be just remain in very stable condition. But of course, you may observe some exposure of the implant, maybe. So I used several cases to emphasize that the surgeon should have. I think we should have the main armamentarium in our hand. In this case, is secondary case. You can see the surgeon's previous effort. They already took some fascia from here. Took some fascia from here. I think probably something happened. It's still not good. So in this case, I think if the TP already used, here already used, I feel reluctant to use the medpor surgery. So I did an effort to use the cartilage again and just take some risk to bury directly under the skin envelope here. But the result is okay. In this case, if we use the medpor, I think the result won't be as good as this kind of condition because we need to cover the fascia. But I think for this case, the fascia harvest would be difficult. In this case, chronic discharge for 10 years, there's cartilage surgery. So I suggest him to take out the cartilage first and then do the surgery. Because there's previous surgery, he didn't want the cartilage again. Although there are some scar on the scalp, and there's no very clear position about an artery on the scalp, but because there's no incision here, so I still harvest the fascia from the scalp and use the medpor for the surgery and put the skin graft on the fascia, and the result is okay. I think that the contour is quite good. Of course, the recovery there's still some discoloration, but I hope in the long-term follow-up it could be better and better. Okay. This is the previous I just showed. This is scar here. Definitely the TPF already been harvested. They're very severe scar here. Actually, it's a skin to the bone. So I decided to take the risk to bury the cartilage directly under the skin envelope here. You can see so tense skin here and very limited. But the cartilage condition is like that. Even though it's very tense, at least it can, for a short time, the still remains stable coverage and the contour is okay. In this case, in the second stage operation, I used the fascia flap based on occipital artery for elevation. Of course, I don't know, another 10 years later, what will happen? Maybe very severe resorption, maybe. So for the presentation today, I think because nowadays most of the surgeon, most of the parents, most of the patient, they may go to the web, the internet, to search the information first. Definitely, when they come to your place, they want you to give them the answer, which option is the best or is the better option. And some patients, they will agree with your decision making, but some won't. No matter how good you think about cartilage or how good you think good with the porous polyethylene, they won't agree with your decision making. So if you want to keep your patient, okay, or if you want to give the patient more freedom, or you want to give yourself more freedom, I think we should prepare both methods in our hand, and you can have some. For some patient, maybe they are good candidate for cartilage surgery. Some patient, maybe they are good candidate for artificial material. So I will first analyze all the pros and cons for them. And if they decide, if they have any decision making, I will respect their decision making. And if for cartilage, and then I may say, oh, okay, you can bury just under the skin, the color texture will be good. And although some resorption may happen, but I accept this kind of situation. And if we do a porous polyethylene, we can say, oh, I can do the custom-made implant for you. We can have very high expectation to the mirror image reconstruction result. So from this point of view, it's not so bad. So this is what currently my approach to my patient. Okay, this is my short talk. Thank you for your attention.
Thank you, Professor Chen, for your brilliant presentation. Now, we have a question from Dr. Desai in Mumbai, and he wants to ask you about your opinion on using prosthetic mounted on osteo-integrated implants, especially secondary cases.
I saw some cases with the prosthetic ear, but because you can say because we are able to do the not so bad or acceptable reconstruction, so we still don't use this kind of approach for our patients. But I saw several patients. The prosthetic ear, the problem is I think we all knew very well already, because for example, the skin reaction to the abutment or the color discoloration for the prosthesis. And one thing I observed in several of my patients, they came from the other area. The patient, they don't apply this kind of prosthesis routinely to their lesion site because they feel just a kind of burden, and they are afraid of falling down over prosthesis. So for them, it seems not so convenient. But in some secondary case, it seems everything has been destroyed. You cannot find anything there. So it's very difficult. You may want to try the prosthetic ear. I think it's true, especially some cancer cases or some very severe trauma case. But for a secondary case, one thing is in surrounding area, it still have some thing available. One is first is a deep fascia. The other thing is the superficial fascia based on occipital artery. Usually the fascia based on the occipital artery, the occipital artery is still, it's spare, not severe by the previous surgery, because we are usually not so familiar with this kind of approach. So usually this kind of two fascia is still available. And if you still want to do the reconstruction, you can still do microsurgery. Anyway, I tried several cases using the microsurgery for coverage. So I think because we are surgeons, sometimes we want to challenge ourselves. But of course, the patient's benefit should be considered. If the patient they really want, and we still have some choices in our hand, you need to discuss with them about the risk and the outcome of the surgery. I think if they say yes, maybe you still can try. But if they can accept the prosthetic ear and the condition is difficult, of course, I think we still can do it.
Okay, and we have Dr. Lizardo with the question that he wants to know your current protocol for pain control, especially for first stage autologous patients.
Uh, 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 no, okay. Many of the patients, they don't want to have a cartilage surgery because they're afraid of pain. Okay, so nowadays, what we did routinely is we use the PCEA for pain control, but epidural pain control. But epidural control sometimes is good, sometimes not so effective. But generally speaking, if the pain score from 1 to 10 without any control, could be 9 or 8, but with control, maybe with 5. But with very good control, maybe 1 or 2. So nowadays we routinely use the epidural for pain control. But I know in some, you can discuss with the anesthesiologist. Nowadays they are emphasized on so-called high quality anesthesia. They can before the extubation, they can give high dose acetaminophen. The patient could feel even better. Or you can use a catheter for direct injection of the long-term narcotics. It's very effective. Nowadays, I use the epidural pain control routinely for 2 or 3 days.
And we have Dr. Wadini asking whether you have used silicone as an implant or even used a mesh plate for the base of the implants.
I don't know if the silicone implants is available nowadays worldwide, because in history, maybe in 1970s or 1980s, it had been about 20 years period of time. Some surgeon, Cronin and Dr. Omori, and they used the silicone imprint for the prosthetic ear for the surgery. It's bendable, it's soft, but nowadays almost all the surgeon we just gave up because of high exposure. They are artificial material, but compared to the porous polyethylene tissue, there's capsule. So once there's a wound, you can easily get infected or you lose your imprint. So at least nowadays, we don't use any kind of silicone ear anyway. But I don't know. But as I heard, some place silicone ear implants still available.
And we have a question from Dr. Professor Yamada, and he would like to ask you whether you have seen infection of polyethylene in the patients, and how do you prevent it?
Yeah. Yes. No. Dr. Yamada, thank you for your question. Actually, talking about infection, I myself in cartilage case, I experience few, but I experience if in cartilage case, if infection happen within the first 2 weeks after the surgery, I think it's very difficult to preserve the cartilage imprint because in that time there's no tissue adhesion, so this infection for me is easy spread out. But for the long-term infection case, I think still you can use antibiotics or some local skin for cartilage. You can preserve the cartilage, although it's not easy actually. For the medpor case, the porous polyethylene case, once you cover very adequately, I think the infection rate is quite low. But or if there's some areas skin loss exposed a little bit, it seems not an urgent issue. You can cover several years, several days later, several weeks later, it remain well, still can be rescued. But of course, the infection can happen. I experienced 2 or 3 cases after the surgery 1 year, less no wound. It just swelling happened, and finally some discharge happened. So from this point of view, the medpor seems kind of some problem there. But but one tricky part about the medpor is even with infection happen, some discharge from the low part of the implant. It seems it's not a high-grade infection. It just looks swollen and discharged, and seems still remain there, not so severe. And I replace because sometimes the condition is quite tedious. The parents, the patient, we don't have very good experience about this. But in two cases, I just replace the framework. We open the wound along the hair colon and take out the previous implanted implant and take out all the granulation tissue and put, because in this condition, after we put a new framework in, usually has some tissue deficient. So in these two cases, I just raise a little bit fascia again to make the wound condition less tension. And I just say the surgery about the cartilage and medpor is similar, but it seems a little different because in cartilage surgery, once we cover not adequately or not without too much tension can heal. But for the porous polyethylene case, if you cover adequate or a little bit insufficient, it seems problem will happen. But if you create fair enough tissue and you obliterate like the plug in the tissue into the porous polyethylene, then you can solve the problem about infection or some shortage of the coverage. You can solve, because it's you need to plug in the tissue, not just on layer coverage. So this is what I learned from the porous polyethylene surgery. So in the case I mentioned, by doing this, it healed and gradual recovery. So so infection may happen, but it's very strange because infection in some cartilage case, it seems you are very difficult to rescue, or if the infection resorption will happen. But in the medpor case, in some cases, it's infection, low-grade infection, it still can rescue or even replace with new framework. It's very different from the cartilage group. Of course, in very severe medpor or porous polyethylene group with severe infection, sometimes I think you may need to take out the implant. I think so, but not so often.
Okay, and Dr. Yan would like to ask you, what is the lowest limit of thickness that you need for a medpor framework in order to balance the contour and durability?
The minimal thickness. When we dice your auricle, you may observe our cartilage maybe 1 millimeter or 1 millimeter, a little bit more. So won't be more than 2 millimeters. So based on this, I think the medpor, if possible, we should make it into 1 millimeter or even thinner. So nowadays, I cannot give you the exact answer about the thickness, but nowadays when I did a fabrication, I may use my hand because to check about the strength of the framework. I won't make it into that kind of paper thin. If you remain several layers of particle, I think the fracture rate is quite low. So nowadays I did not experience a little bit high exposure rate in the previous surgery. Nowadays, in my hand, the fracture rate is, I think it's quite low actually. But I think you can get a balance. Okay, if you because anyway, stability is very important for a surgery. So you can get a balance. We don't always need to struggle for best outcome. Sometimes it's balanced and stable outcome is best for the patient and best for the surgeon.
And Dr. Kachin would like to ask you, what is your preferred option for low hairline cases?
Prefer approach?
Yeah.
Right? I think Dr. Yamada probably could answer this question better than me. Okay, because usually in the low hairline area, even we can print in that area the skin is more tense, and it's not good idea for you to just put your framework just under the hair-bearing skin. So usually what I learned from Dr. Nagata is we take out a follicle, and we may create this area into split thickness skin graft and cover with the fascia flap and put back the split thickness skin graft for coverage. But if I think if you are possible, for me, I observe if possible, the area it seems better to you take out the follicle and cover with the fascia flap, and better, I think it's better to cover with full thickness skin graft, so you have better chance to get better color and better texture of your auricle. And I think the better donor size from the conservator auricle, except is a by the case you don't have a choice. But I think in most conditions nowadays, I may take the skin from the conservator auricle, especially for porous polyethylene case. I don't know if Dr. Yamada agrees with my opinion or not.
Professor Yamada says he agrees with you. Okay, and for our next question, Dr. Liao would like to ask you what is the ideal age for the usage of porous polyethylene implants?
Ideal age, I think for me, because in order to decrease the tension or in order to get the adequate coverage, usually we will raise the fascia flap for coverage. So the fascia flap is easier for harvest in pediatric patients. I mean, in age of 5, age of 6, age 7, 8, 9. Okay, usually it's easy because not so adhesion, and the fascia itself is thin. So for after coverage, it looks good. So, but if a male adult patient came to your place, usually the scalp area, the fascia is thick, especially in some very muscular type patient, the fascia could be thick, and the digestion very tedious, maybe breathing a lot. So in adult patient, especially in some patient with very oil acne skin, you can predict more scar tendency. So generally speaking, the porous polyethylene group, the younger age, the result is better. And for the white skin, thin skin patient, the result is better. The female patient usually is better than, adult male patient. But if you say what is the best timing, what I can answer you is only the younger is better.
And we have Dr. Koo who would like to ask you for medpor reconstructions. What is your incidence of implant extrusion, and how do you prevent it from happening?
Okay, very often we saw in microtia field, the tricky part is For example, Dr. Yamada, Dr. Akira, or Peter Koo, or Dr. Nagata, they can present you with very good result, and the complication rate is very low. But in your hand, we cannot create that kind of good result, or our complication rate is higher than their cases. So if you ask me about the exposure rate nowadays in my hand, I just can say I am not so afraid about the exposure. And exposure rate maybe is not so often. Usually not in my mind. It's not that kind of severe problem. Okay. Or you say maybe 1 in 100 cases, or it's okay. I accept. Or if the exposure happen, you have the ability to rescue it. It's okay. But if you want to ask me about my early experience, or some surgeons' early experience, if you are a new beginner, you may have 40% of exposure. So depends on your learning period of time, or depends on how the condition you create for the surgery. It can be very low, it can be very high.
Okay, and we have Valerie who would like to ask Professor, what is your view in the future development in the field of microtia reconstruction?
Okay, I think that you can see the surgery. We have 2 issues. We need to treat 2 issues. One is the framework, and the best framework is the framework has the same characteristics as cartilage, so you can have the best wound healing. You don't need to worry about necrosis or fascial coverage something. So if the cartilage, I think the tissue engineering cartilage maybe can provide this kind of future. But actually from my observation, the scaffold is the big problem actually. So we are very difficult to get the so-called tissue engineering cartilage for the surgery with the same character as the cartilage. So if we are able to get some new material with the same quality of the cartilage and it's soft, I think it's the future. But the soft tissue treatment is still the principle. You need to know, because in the microtia surgery, it's not just the skin coverage. It's just not something about a wound closure. It's about a very good wound closure, right? So if one day we are able to get a very, implant with very high tissue compatibility and could be custom made easily, and you learn all the tricks about the soft tissue coverage, and then probably will be the answer. But I think for most of patients' answer is that they want the hearing reconstruction at the same time. This is another issue. So nowadays, at least, I think I still need to do the surgery based on my hand to do some trouble work. But in the future, I hope we can have new implant and some very new concept, or some tissue engineering process, not so difficult process.
Okay, Professor Chen, since everyone has been asking mostly about medpors, I would like to ask you a question on reconstruction myself. What is your opinion on the resorption that is caused by cartilage reconstruction? And is there a way to prevent it, or at least decrease the incidence?
I think for the cartilage surgery, the difficult part is initially we cannot decide which cartilage is best for a surgery. Although there are still some coming study, we want to study the quality of the cartilage before the surgery. But for me, I cannot make a very good link between the clinical work and my image study. And every process has some impact on the resorption rate. Your harvesting of the cartilage, you injure the cartilage or not, you bend the cartilage or not, and your skin tension. For example, in cartilage groups, we did not, actually, usually we cover the framework just based on the skin quality, not based on the tension, the skin quality, the hairline, yes or no. But we did not classify the skin quality into thin, into thick, into tight, into loose, right? So many issues we did not know very well. So for me, we just need to follow the principle and adequate coverage, less trauma, something like this. I hope Dr. Yamada can answer this question.
Dr.
No,
Yamada, would you like to comment on this topic?
You know, the Dr. Chen, Professor Chen, this is not easy topic, but I think we should explore the what's the reason for that. We don't know yet, but probably we should do some study together and to find out what's the cause. What's causing this? This is people don't know. We don't know, and I agree with you. The cartilage reconstructions sometimes cause the long-term resorptions at the helical rim portions. Probably something about the tensions, something about blood supply, but we don't know. And so we should do more explore that. I 100% agree with you. So that's why now I know why you're using the PPE for a certain population, because it does not cause the resorption at all, right?
Okay. Okay, I think there's no more questions so far, and I think time is limited. We are so thankful for the great talk from Dr. Zung-Chung Chen today. I think today is the current in the recently 2 years. I hear the most word you talk to us. Otherwise, you are always very shy. Yes, so I think everybody here is not satisfied at all. So we are looking forward to you further talk next time. And I think Dr. Chen is very happy to see a lot of friends, Dr. Yamada, Dr. Peter Gu, and Kachin, and so many friends. Yeah, even those in the pandemic period. Okay, so three webinar in a row in the recently 3 weeks. I think we are so busy. So our next webinar is 3 weeks later. Our next speaker is Dr. Zhu Yongming, and he will share his experience in 3-dimensional design for the orthodontic surgery. And we are looking for next webinar as well. So thank you, Professor Zung-Chung Chen again. Can you wave your hand to all of your audience today in front of your screen? And
Thank you.
Thank you for all our friends. Thank you and
Thank you.
bye-bye.
Thank you, Professor Chen. I'm gonna come to learn from you, PP, in the future after the COVID.
Okay. Okay. See you.
OK，谢谢聪哥 ，Thank you。
谢谢。关掉。
OK，Have a good night。 Bye-bye.
Bye-bye.